On-the-scene video coverage of TCT 2012 is supported by Prodexa.
Good morning, all. RESPECT is a clinical trial that's addressing an important problem, and that's secondary prevention of stroke in relatively young people between the ages of 18 and 60. This is my disclosure in terms of research and time support for being part of this clinical trial. So understanding stroke is very important to understand why RESPECT had to be done and interpreting the results, that this is a common disorder, that this is a disorder that leads to major disability and cost, and that in many of these patients we have a situation where they have a cryptogenic stroke, which means we don't know why they had it, and therefore we really can't get to the basis of a therapy that deals with the potential mechanism of that. Over the last few decades, a possible mechanism in some of these young people has come up, and that's called paradoxical embolism. That is, a small blood clot that otherwise would go to the filter organ of the lung can go through this flap within the heart called a patent foramina valley, which is a common finding in adults, 25%. And this paradoxical embolism, if it crosses into the left side of the heart, can go to the brain, and a 2-millimeter little clot can in fact make someone suddenly paralyzed in part of their body. So no one knew whether this mechanism was really very commonly active, and how do you test that, how do you offer a new therapy, and that in fact is what this is about, providing a catheter-based therapy that deploys a device that acts much like a cufflink to hold that flap shut and therefore prevent the transit of these small blood clots across a PFO up into the brain. The trial design was a prospective randomized trial. The sites in the US and Canada were included, and there were two groups or arms, those randomized to the device, those randomized to standard medical therapy that's guideline driven. There were 980 patients enrolled, although the stopping point of the trial was that this was event driven. So it was after 25 endpoints occurred, and the endpoints in all these patients were recurrent, non-fatal ischemic strokes. 49% of the people entering the trial really had large strokes. These were significant. These weren't spells. So to get into this trial, you had to have an ischemic stroke of unknown cause and a echocardiographic diagnosed PFO. The sponsor is St. Jude Medical. In these trials, we use a variety of different ways of looking at the data. The intention to treat cohort is the standard, and the raw count analysis was the basic mechanism by which the results were going to be analyzed. But it requires that both groups are randomized equally and they're followed up equally. If they're not, then this type of analysis becomes invalid. And as all these analyses were pre-specified, then it would default to an event-based, a Kaplan-Meier. Per protocol and as treated are other types of analyses that were pre-specified to look at this data to give a totality of overview of what the results were. And here, in fact, we see the efficacy results, and we see a risk reduction of stroke in favor of device that was present in all groups. Again, the raw count analysis was deemed invalid because there were more dropouts in the medical arm. This trial took 8 years to complete, and during that period of time, people could access off-label PFO closure, and that did occur in some of our patients. What we can see with all these analyses, the device performance with risk reduction, and we can see no early hit that patients take. The safety results are really quite incredible from this procedure and this device. And we see in the per protocol and as treated a significant risk reduction. Noteworthy, the device group here of the 9 patients who had recurrent events, in the device group, 3 of them did not have a device in place, and that's one of the reasons we feel it's important to look at these other cohorts. So we conclude from this data and other data that in carefully selected patients with a history of cryptogenic stroke and a PFO, that this provides evidence of the benefit in stroke risk reduction from closure with this particular device over medical management alone. The primary analysis with the intention to treat cohort was really borderline, formally statistically not significant, but trended towards superiority, while these secondary analyses suggested that there was superior treatment. The risk reduction was significant. The procedure and the device have excellent safety results. And we think these results will have a substantial impact for the treatment of patients with a history of cryptogenic stroke and PFO. This really provides an amazing amount of evidence-based medicine to this field that was lacking it. And these patients continue to be followed up, so we will have more results as these patients continue to be followed actively in this trial until there's a regulatory decision. Thank you.
Okay, why don't we have some questions from the press?
Larry Hamovich, Medical Device Daily. Dr. Carroll, in the Closure 1 trial, which I'm sure you're very familiar with, there was a higher adverse event rate, particularly atrial fibrillation. That was one of the real bugaboos of that trial. Can you comment about the atrial fibrillation rate or other adverse events in this trial, please?
Good. The atrial fibrillation rate was statistically not different between the 2 groups, device versus the medical group. So that was a significant finding. It was 3% in the device group, 1.5% in the medical group, and that was not significantly different. Other serious adverse events, there were 2 patients in the device group who required pericardial effusion drainage during the procedure. There were no device-related thrombi that were found, which was another finding in Closure that gave rise to what we were trying to prevent. And so I'll go into this in more detail both later on and also when the publication comes out.
I did not, and neglected to introduce the discussants. Ted Feldman from Chicago, Alice Jacobs from Boston, both highly skilled interventionalists and very well known. Just quick comments, your thoughts, very brief, and how you'd summarize this, and then we'll go back to another question.
I guess we need to put the totality of evidence together, and I would ask a question here.
Can we get the microphone?
I guess it'll be left for us to put the totality of evidence together. This is, when you look at intention to treat, it's not a positive study, but when you look at the other analyses, it's heartening. Results that we have been looking for. I guess my question to help put this in perspective for the press and certainly for us is, why does this study differ from the other studies? Is it patient population? Is it the device? Is it the way you analyze the data?
Yes, 3 excellent questions. Number 1, this was different from Closure, and that's important. This was a well-defined cryptogenic stroke population. No TIA patients were included in this. And this was tightly defined, and Dr. Saver tomorrow will present the neuroimaging data that will help substantiate that this was a good target population. Secondly, this was a different device than was used in Closure, and the safety is key in providing these patients benefit without exposing them to risk of, in fact, recurrent stroke, and that data will be substantial. And thirdly, this was a study that was designed not as a certain number of people to enroll, but keep enrolling until you meet certain numbers of events. And what did that result in? As you saw with the Kaplan-Meier curves, this resulted in follow-up up to 8 years in some of these patients. And if you're a 46-year-old, you've had a stroke, and you want to prevent another stroke, you're not interested in results 1 or 2 years. You're interested in the next 4 decades you're going to be alive. And so this particular study design gives longer-term data that continues to accrue that is critically important.
Great. Just also that issue of the age is really, I think, very, very important. When many people think of stroke, they think of their elderly relatives, people quite advanced in age. This population is different. This is perhaps any one of us sitting here on the panel having a stroke and being confronted with a choice of medical therapy, which we have no real idea of how efficacious it is or what we should use versus for a lifetime versus a device and then coming off the therapy. So Ted, tell us how you go through this when you treat individual patients, because you do a lot of these.
The probability that the stroke is related to the PFO is one of the fundamental problems in selecting patients, and John's alluded to this with the trial selection criteria being rigorous in terms of requiring a stroke, and it was, do I understand correctly, imaging defined, so that the potential for patients who have complex migraine, for example, which is a whole nother subject with PFO, are taken out of this kind of a trial. If you treat a 70-year-old with a PFO and a stroke, the potential that the stroke etiology is hypertension or vascular disease or intermittent arrhythmia becomes very cloudy. In this younger population, the likelihood that it's due to the PFO increases. Mean age here was 44 or 45?
46.
And the youngest patient, I'm going to guess, was probably 18, which
That's
would be
correct.
the bottom end
18
of
to 60.
the trial inclusion criteria. So in a 23 or 25-year-old, there are fewer confounders. But this is the issue. When you talk to a patient, when you counsel a patient about a decision for a procedure like this, it's a probability discussion. You can't tell anyone you're going to prevent their next stroke. You can tell them the likelihood that you're going to reduce their risk over a period of years. And these data are spot on consistent with meta-analyses of probably about 5,000 patients in non-randomized trials that have been published over the last several years, and I think highly confirmatory. So I'll take Dr. Jacobs' comment that in the context of the totality of what we know about the field, this is a extremely positive and important finding.
Any questions from the audience?
I guess just I'm Michael Reardon with theheart.org. Just to follow up to that, these trials are really kind of hard for the press to kind of wrap our heads around. It's, you missed your primary endpoint, but you have a secondary analysis that kind of showed benefit. Jumping ahead to the next trial, that missed its primary endpoint too, but yet you're very heartened, you say, by the results. I guess it's not so much a question as to sort of how do we take this data right now with closure being kind of what it was, and I mean, I know this is what's going to be the big issue, is how this trial gets interpreted over the next day or two. So I just don't know if you could respond to something like that.
I think your points are well taken, and you certainly quote the results of the trial well in terms of the intention to treat cohort. 0.08 is not 0.05 in terms of the p-value, but it is the interpretation of these trials also involves making judgments in terms of to what degree is it reasonable to look at these other analyses? To what degree does this fit into the context of what we know? To what degree does this make PFO closure a real treatment that now I think has been shown to be effective? And now we're talking about the statistical superiority endpoint of the intention to treat not being met, but with these other cohorts. So I think it is integration of all the trial results, and it is putting in the context of what we've been dealing with over several decades of the lack of any randomized trial data and the importance of really precisely defining the patient cohort you're studying, because small differences there can determine the trial results, and also the safety of the device and the procedure become key in bringing that out. And I think you see all those things do come together in this trial.
One more question. Irma, there are no questions on the line,
no,
correct?
This
Go
is
ahead.
Lynn Peterson with Trends in Medicine. So with the 4 analyses being pre-specified, how was the discussion with the FDA on those analyses? Because normally an ITT analysis is required for an FDA approval, and what do you see as that regulatory path?
This study has been repeatedly discussed between the sponsor, the steering committee, and the FDA. They certainly have, in the last decade, been very supportive of the need for doing randomized trials, of the commitment that it takes from a sponsor to complete such a long trial, especially with off-label closure going on and making enrollment sometimes difficult. And they certainly were aware of the differential dropout rate and the impact on our raw count analysis, and that's why this was all pre-specified, these other analyses to deal with these issues. So I think we look forward to a rigorous and hopefully timely regulatory next step because that's part of the process that we're engaged with and we want to see happen and will happen.
Great. So I think
could I just do one more little one?
little.
When I look, you didn't provide us, I assume you're going to do it in the session, with the actual hard numbers. You gave us the percentages. If I look at the Kaplan-Meier and draw it across, it looks like it's a very tiny difference between these. It looks like it's the probability of being event-free by the raw ITT is roughly 96% versus 93.5%. And then if you get your best analysis of as treated, 98% versus 93%, these are your percentages, 72%, 46%, whatever. These are huge.
So
but the numbers, the absolute numbers, look really small to me.
Sure, and that is correct, but you really have to consider the following. Number one, we're talking about a stroke risk reduction that, if it plays out over time in a 46-year-old, is important. Secondly, what are patients who are in the midst of their lives, careers, family, who have a stroke looking for? They're looking for what is the best strategy to reduce risk of having another stroke with all those consequences. So what's a small difference to you is a huge difference to these patients. And thirdly, when you look at pharmacologic studies that look at risk reduction of secondary prevention of stroke, you're really not dealing with the same magnitude. These magnitudes of risk reduction are substantial. So I think those are the important things to keep in mind in interpreting this data in this patient population.
Okay. Great. Well, I'm sure we'll be able to continue this after the next discussion. So let's thank John.